Thank you. Welcome to the welcome to today's lecture on the management of primary Sjogren's disease and antiphospholipid syndrome, part of the medicine PG lecture series. I am Dr. Koshy Nithin Thomas from the Department of Rheumatology. So these are two unique disorders that revolve around two organ systems. Apparently, primary Sjogren's, which predominantly revolves around the salivary and the lacrimal glands, and the antiphospholipid syndrome, which revolves around the coagulation cascade. But at the same time, these two diseases can present with multiple fascinating features and can often baffle you. So this will be the outline for today's talk. I'll start with a basic approach to Sjogren's pathogenesis, which may help us in understanding the role of the different therapeutic agents that are used in this disease, and then come to a basic approach to the management of Sjogren's disease. Then we'll come to the treatment recommendations of antiphospholipid syndrome and some discussion on NOACs and rare presentations of APS. The objective of my talk will be to give a brief overview of the approach to these two diseases and their management. So Sjogren's syndrome is a prototypical autoimmune disease, characteristically associated with dry eyes and dry mouths in the presence of high prevalence of autoantibodies to the Rho and La antigens, with a good proportion of patients having systemic involvement. But if you look at the classification criteria, it is confined to the lacrimal gland and the salivary gland. There is no systemic feature that is part of the classification criteria. As we know that classification criteria are meant to ensure homogeneity, especially for research purposes, but also give a good understanding of how the typical disease should look. So just like the skin in systemic sclerosis or the muscle in inflammatory myositis, the focus of interest in Sjogren's disease is the salivary gland. It can be the duct or the acini. So where does the disease pathogenesis start? Is it the acini or is it the duct? Data suggests that probably the acini is not much affected. This is because there's not much of loss of acini. There's not much of apoptosis that has been seen in the acini. Second possibility is that there is a functional dysfunction of the acini, which could result in decreased secretion of saliva. And there are antibodies against muscarinic receptors to support this postulation. But the current understanding of the pathogenesis of Sjogren's is that it basically focuses in the salivary gland epithelial cell or the ductal epithelium. The ductal epithelium is a portal of entry for viruses, and there are epitheliotropic viruses, which are considered to be one of the major contributors to the onset of this disease. There may be multiple known and unknown factors. Epitheliotropic viruses such as Coxsackie viruses, and they enter the epithelial cells and result in activation of multiple intracellular pathways. Most characteristically, it will be the activation of cytoplasmic and endoplasmic TLRs, resulting in activation of what probably everyone knows is the interferon pathway. But there is activation of the inflammasome and other intracellular pathways as well. Now, this is not very different to something we had seen a few years ago. Another virus which is very epitheliotropic was the COVID, and the COVID virus was very epitheliotropic for the respiratory alveolar epithelium. I'm not trying to make comparisons because this is very different. And as you can see that there is not much of apoptosis of these cells, as I had mentioned before. But there is upregulation of cytokines, release of chemokines, which are going to bring in multiple lymphocytes to the salivary gland. There's going to be upregulation of multiple MHC molecules on these epithelial cells, multiple co-stimulatory molecules. Therefore, these epithelial cells are going to start behaving like antigen-presenting cells, resulting in activation of not only the migration of lymphocytes by chemokines, but also the activation of T lymphocytes as well as B lymphocytes. So slowly you're developing a niche here for proliferation of lymphocytes. Now, one main lymphocyte that is has a main role here is the B lymphocyte. And the B lymphocyte is activated by virtue of multiple cytokines, especially BAF, the B lymphocyte stimulator, and interferon alpha. They will result in increased B cell survival as well as B cell proliferation. And the release of other cytokines such as interleukin 21 are going to ensure that there is going to be development of, development of a germinal center. So finally, this is what the pathologic picture is going to look like. There is something called an epithelial cell B cell crosstalk, where both facilitate each other's survival as well as proliferation, resulting in formation of lymphoepithelial lesions, which are very characteristic of Sjogren's disease. Epithelial cells will release, as I had mentioned, BAF and interferons, which in turn are going to help B cells in producing autoantibodies, interleukins, which are going to help in formation of germinal center and therefore the maturation of B lymphocytes, conversion to plasmablasts, production of autoantibodies, especially anti-Rho, anti-La. And the B cells in turn are going to release cytokines such as interleukin 6, which are going to also help epithelial cells proliferate and survive. Now, this is going to be the basis of the pathogenesis of Sjogren's because it is not confined to the salivary gland. You have epithelial and similar structures in other organs in the body, example, even the kidney. But the autoantibodies and these cytokines, interferons are not confined to the salivary gland. They are in circulation as well. And this contributes to predominantly all the clinical features that this disease produces. There is something very unique about Sjogren's if you compare to other autoimmune diseases. As you can see in this picture, in a germinal center, you expect T cell, B cell interaction, and you have two characteristic features, class switch recombination and somatic hypermutation, which will enable increased specificity of the B cell or increased specificity of the immunoglobulin. But what you always see is an oligoclonal expansion of B cells. Sjogren's is a little different. Sjogren's, as you may know, has an increased risk of lymphoma compared to other autoimmune diseases. Even rheumatoid arthritis, SLE, all do have an increased risk. But as we have been discussing for some time, it is significant B cell survival, B cell proliferation, and other factors that contribute to an escape, a monoclonal proliferation of B lymphocytes ending in the formation of a lymphoma. So this lays the basis for all therapeutic targets in Sjogren's disease. Very simply, you can see that there are three cells here, the plasmacytoid dendritic cells that are key producers of interferons, the T lymphocyte and the B lymphocyte. And most of the drugs target these molecules, either anti-BDC and JAK inhibitors for BDC and interferons, anti-CD20, BAF, anti-BAF receptor for B lymphocytes, or you have targeting of receptors on the T lymphocytes, or anti-CD40 that is required for T B cell interaction and multiple functions. Not only that, we've progressing into intracellular targets, and there are small molecule inhibitors that are targeting B cells that are being used in Sjogren's disease. So there's a lot of molecular pathology here. But what is the basic approach to treatment in Sjogren's? One would seem that it could be either glandular or systemic, a disease that is confined to just the salivary and the lacrimal gland, or a systemic disease. But what is very important is to understand that the type of organ involvement may vary from a very simple, or not simple, but a small fiber neuropathy to a NMOSD spectrum to a cryoglobulinic vasculitis in the neurological spectrum of Sjogren's disease. And you have variable treatment for all of these conditions. So what is the pattern of organ involvement is very important in this disease. But what is central to the treatment of this disease is the treatment of pain, fatigue, and dryness. That is because pain, fatigue, and dryness in Sjogren's contributes to significant decrease in quality of life of these patients. So while you may find it difficult to handle some of the major systemic manifestations of Sjogren's, you will always have to handle pain, fatigue, and dryness in these patients. It appears that we are spoiled for choice in Sjogren's disease, looking at all these molecular targets that is in front of us. But actually, there is really only one molecule that has really made an impact in this disease. Most of the drugs have failed and continue to fail due to multiple factors, part of clinical trials, outcome measures, many features. This molecule is hydroxychloroquine, a simple molecule that targets the endosomal TLRs or the endolysosomes and results in decreased activation of the endosomal TLRs and downstream signaling. Other molecules that have shown some benefit are, as we have discussed, molecules that target the B cell. And finally, another really good molecule, abatacept, which is a fusion protein of the CTLA4 with the FC portion of IgG, which has been successful in multiple diseases and has shown some benefit in Sjogren's also. Remaining are, well, they're trying their best. So coming to hydroxychloroquine, there have been some trials and some cohort studies that have shed light on some significant information on this drug, on its effect in Sjogren's disease. The Joker trial was actually a failure, but the post-hoc analysis showed that it did have benefit in some people who have a very high symptom burden. High symptom burden, apart from pain, fatigue, and dryness, very often involves anxiety and depression also, which are part of this a cluster of symptoms that result in reduced quality of life in Sjogren's. The repurpose trial was a trial that combined hydroxychloroquine with leflunomide. That also showed, it was a positive trial. It showed some benefit in Sjogren's disease. And then was a long-term cohort study. So hydroxychloroquine reduces pain, fatigue, dryness in high symptom burden patients in Sjogren's. It reduces oral sicca. It reduces arthritis, as we know. Purpura, it is a good drug for purpura. But what was very significant and what came out of the KISS cohort study was that there is less solid organ damage. Predominantly it was neurological, nephrology, pulmonology at 3 years for patients who were on hydroxychloroquine compared to those who were not on this drug. The second drug that has shown benefit is rituximab. There are 2 trials and post-hoc assessment of these trials. And they have also shown improvement in salivary flow rate. Now, they are being highlighted. I highlight these points because most drugs have failed to produce a significant improvement in salivary flow rate or dryness or pain or fatigue. These 2 drugs have. And without saying, in general, rituximab has a beneficial effect in systemic involvement. So you choose on a case-by-case basis in Sjogren's, as you would do in any systemic autoimmune disease. The drug that you choose would be based on the clinical picture that the patient has, can vary from conventional synthetic DMARDs to biological DMARDs to alkylating agents. So systemic disease, is it immunosuppression in all? Is that the way for Sjogren's disease? So there are some manifestations of different organ systems in which immunosuppression has failed or actually may not be warranted. If you look at the skin, purpura, especially of the lower limbs, or what is known as hyperglobulinic purpura Waldenström's, is something that is a little difficult to control. And very often you end up giving patients steroids. But the problem is, as soon as you taper it, it comes back. It really is not warranted. You may use it for a very short while. Small fiber neuropathy and sensory axonal neuropathy. The fact is that, again, the drugs have failed in these conditions, but these are disturbing symptoms for the patient. There is evidence for some immunomodulators that may have a role, but by and large, the recommendation is that you do not use immunosuppressants in these 2 conditions. Renal tubular acidosis, which may be part of interstitial nephritis of Sjogren's disease. Again, generally, you just have to use your Scholl solution, and that is something that is going to control your renal tubular acidosis. But there is debate regarding whether you should treat interstitial nephritis. There is evidence to suggest that there is improvement, but at the present stage, there is no recommendation to treat. Finally, airway disease and pulmonary organ involvement. So as you can see, it is very important to understand the pattern of the organ involvement in Sjogren's for you to make the right decision in treating this group of disorders. Now, what is central to our treatment? We will not see systemic involvement is seen in around 70% of patients with Sjogren's, but you will have Sika in majority. There are cohorts which are there without Sika, but this is something that you will manage all your patients. And first, lifestyle changes. You have to ensure there's adequate humidity, because reduced humidity can result in increased ocular Sika. Avoid air-conditioned rooms or overheated rooms if possible, if it is permissible. Lubricant eye drops. Some things that one must note are they should be preservative-free eye drops because they may produce irritation. Common use eye drops are carboxymethyl cellulose and hydroxypropyl methyl cellulose. There is suggestion that combination may be better, but this is not usual practice. Other agents which are very beneficial are sodium hyaluronate, and again there are suggestions that it be used in combination with carboxymethyl cellulose or with trehalose. These are all available actually. If you look that sodium hyaluronate with trehalose combination is actually available inside the CMC pharmacy also. So it's a combination lubricant eye drop that is available. Then people who have increased evaporative eyes, there is suggestion to use polyvinyl alcohol or lipid formulations. The recommendation is to use 2 to 3 hourly eye drops, but at least 4 times a day. At least 4 times a day. And for people who are not controlled with this, then gel formulations or high viscosity formulations at bedtime. Generally, the signs lag behind symptoms. Now, trials have used both VAS as well as objective, and both have failed, but the general impression is that signs lag behind symptoms and may take at least 4 weeks for some improvement. If it fails, if you are unable to control the Sika with your topical application, you can topical lubricants, you can resort to steroid eye drops with caution, or immunomodulator eye drops, especially cyclosporin or tacrolimus. Other eye drops that are in the pipeline or actually are available right now are lifitegrast, rabamipide, and dicosofol, which are different immunomodulatory eye drops. Sometimes, how much ever you treat, you cannot solve their ocular Sika, and very often they have meibomian gland insufficiency also. Warm compresses can help in, or even short courses of antibiotics such as doxycycline can help in reducing this. Finally, if everything fails, then you will have to do punctal plugging, initially inferior, then superior, which will help in, which you hope will help in solving the patient's ocular Sika. This is the recommendation from the European League Against Rheumatism, where they suggest that one must first do a risk assessment or a scoring, 2 ocular scorings, whereby they are classified as non-severe keratoconjunctivitis Sika or severe. Both you will use artificial tears with ointment, and the severe keratoconjunctivitis Sika, you will resort to topical corticosteroids, topical cyclosporin. Another type of eye drop is serum eye drop. I don't mention that, serum eye drops, but these are not available in most places. And finally, oral muscarinic agents, which may also be beneficial in these patients. Now, what about oral Sika? You may use non-pharmacological stimulants. They work. If there is residual function, they will work. Especially, you must use, it is recommended to use sugar-free chewing gums. I will not advertise, but there are many that are available. Pharmacological stimulants, such as saliva spray or oral medications such as pilocarpine, which are muscarinic agonists that you know, or even cevimeline, both are useful in oral Sika. Regarding pilocarpine, because this is again available and useful, is generally you start slowly, give at 1 tablet a day, and you can escalate to multiple 3 to 4 tablets. Be weariful of glaucoma, patients who have glaucoma. They may have increased sweating, diarrhea. These are things that you know, but one must be alert of it. This is especially because Sjogren's is a disease that, unlike SLE or many of the other autoimmune diseases, develops in elderly, not elderly, but at least 4th and 5th decade females very characteristically. So as the age advances, they may have increased tolerance to these sort of drugs. Finally, oral hygiene is of paramount importance. Use of fluoride toothpaste. Xylitol and chlorhexidine both have shown to have some beneficial effect on in controlling especially Streptococcus organisms, but the evidence is weak, but it is still suggested that they may be used. Daily flossing is something that can be recommended. Artificial saliva, not very often available, hypromellose and methylcellulose. Always look for dental caries and oral candidiasis, and you should treat them. You may not always get a wet thrush. You can also get a red tongue and oral cavity. And these are the, again, recommendations for management of oral Zika, with again a risk stratification based on initially an unstimulated whole salivary flow rate, followed by a stimulated salivary flow rate. And if it is very severe, they suggest to go straight to saliva substitutes that suggest that there is no residual function in these glands. This is not something that is specific to Sjogren's. This is something that is related to anti-Rho antibodies. It can be anti-Rho antibodies in SLE. It can be anti-Rho antibodies in any autoimmune disease. One must know that there are very few evidences for actual pathogenic role of autoantibodies. It's not very evident. This is one condition where there are some postulations, and where the antibody may actually be responsible for the production of this pathological condition, that is congenital heart block. The fetal heart at the time of cardiac organogenesis will be undergoing cell replication and apoptosis, and this will result in display of multiple antigens on its surface, of which one may be Rho52 or TRIM21. And the presence of maternal antibodies in the fetus can result in binding to these antigens. And this is one of the considered pathogenic pathways for the development of congenital heart block in children of mothers with anti-Rho antibodies, especially anti-Rho52 antibodies. What is the recommendation? So, there is a 2% risk for the first pregnancy for the child to have congenital heart block. In a mother who has already had it once, in the second pregnancy, the risk goes up close to 20%. So how will you screen? You should start screening at 16 weeks, which is roughly at the time of cardiac organogenesis. Recommendations are variable, but generally you would go fortnightly from 16 weeks to 24 and then weekly till 28. If there is a first degree heart block, first of all patients, all mothers who are all women of reproductive age group who are planning to get pregnant should be on hydroxychloroquine. This is because hydroxychloroquine has shown a more than 50% reduction in fetal demise in patients who have anti-Rho antibodies. So again, this is a drug that works wonders in this disease and also in patients that have this antibody. So they should be on hydroxychloroquine. All patients should be started on hydroxychloroquine, after which you will start screening. And at 16 weeks, if the patient has first degree heart block, you will start the patient on fluorinated glucocorticoids. Betamethasone or dexamethasone more commonly. If there is a second degree heart block, recommendations again for glucocorticoids with IVIG, and in most of the evidence suggests that complete heart block will not generally revert, and you will have to use or insert a fetal pacemaker to revert this complete heart block in the fetus. Finally, watch out for B symptoms in patients with Sjogren's. The probability of lymphoproliferative disorders in Sjogren's disease is about 2.6% at 5 years and 3.9% at 10 years based on large cohort studies with long-term follow-up. There are different values and there are different time periods at which one may develop lymphoma. There is difference for young onset, late onset Sjogren's. So it may vary, but the point is that one must be alert because of this property of the B lymphocyte to undergo monoclonal proliferation. There are different studies have come out with different risk factors. Generally considered risk factors are low complements, especially low C4. Clinical evidence of persistent salivary gland enlargement. Clinical evidence of lymphadenopathy, cryoglobulinemia, monoclonal gammopathy, and actually your histopathological focus score also seems to be a predictor of development of lymphoma. So this is in brief an overview of management of Sjogren's. I've not gone into management of individual organ pathologies, but this is an overview of how most of the organ systems will be managed. Next, we come to antiphospholipid syndrome. So as the salivary gland is a focus of interest, the clotting system is a focus of interest in antiphospholipid syndrome. It's a very strange condition where you have in vitro coagulopathy by virtue of antiphospholipid antibodies binding to phospholipids and resulting in impaired clotting, and in vivo thrombosis. It's a very unique disease. So in vivo thrombosis, because antiphospholipids have effects beyond just the clotting system and on multiple cells, from endothelial cells to the monocytes, all of which can result in increased thrombosis. This is the modified Sapporo classification criteria that has been in existence from 2006. So for almost 17 years, there was a new criteria that came out in 23. 17 years, this has, though it is a classification criteria, this is very often used as a diagnostic criteria, and most doctors would be hesitant to make a diagnosis outside the realm of what has been described here, that is vascular thrombosis or pregnancy morbidity. This disease requires the presence of autoantibodies. There are some other conditions that require the presence of an antibody for classification or diagnosis. It is not mandatory. There are some classification criteria that have entry criteria. This disease requires the presence of autoantibodies, and not just the presence of antibodies, present at certain titers. They have to be present at moderate to high titers we consider as significant for classification as antiphospholipid syndrome. You're all aware of this. I won't go into naming them and all that. So coming to straight to recommendations, I'm not going to this. This is not something as an overview. This is recommendations for management of antiphospholipid syndrome. This is as put forward by, again, the European League Against Rheumatism in 2019. First case scenario is when you have isolated antiphospholipid antibodies in the absence of clinical criteria. This is something that we come across very frequently. The patient either had vascular thrombosis, nor did the patient have obstetric morbidity. So they came with a description, which probably all of you know, which is known as a high-risk profile, where on 2 occasions, as is mandated by the criteria 12 weeks apart, you must either be LAC positive, the patient must be lupus anticoagulant positive on 2 occasions, must have something called a double or a triple positivity, or high titer. So high titer is on the ELISA defined as more than 80. So if you have any of these features, you classify as what is called high risk profile. This is because of many reasons why they call high risk. One is because of a thrombotic tendency, but also because there's a high chance that they will remain positive. You must remember that they mandate it to be positive twice because many of them actually turn negative. What is the recommendation if you have isolated antiphospholipid antibodies in the setting of high risk profile? So throughout the recommendations, as any recommendation they have is recommended, may be recommended, and all of this. And this is low dose aspirin is recommended. What if the patient has SLE and has isolated antiphospholipid antibodies? Again, without clinical criteria. Again, if there is a high risk profile, it is recommended. Low risk profile, it may be recommended, because we must understand that it comes with the risk of bleeding. What about non-pregnant women with history of obstetric APS? So the lady had past history of obstetric morbidity, and she has the presence of antibodies. What do you give her? We don't. We will be coming to that obstetric APS management. We stop anticoagulation 6 weeks postpartum, and you do not continue anticoagulations after that in patients who have obstetric APS. So this is a lady or women who have persistence of antibodies and have a past history of obstetric APS. Low dose aspirin is recommended after adequate risk benefit evaluation. This again taking into consideration the risk of bleeding that is associated with aspirin. But there is a definite benefit. The pooled odds ratio for first thrombosis associated with the use of low dose aspirin was significantly less. But this is a statement that is put forward, and physician discretion is what is used. What about venous? Now you have a clinical criteria, that is venous thrombosis with antiphospholipid antibodies, and the asterisk is to say that antiphospholipid antibodies meet the criteria as put forward by the committee. It is not near positivity. First, unprovoked thrombosis. You will start on vitamin K. It is vitamin K antagonist, and it is with a target of INR 2 to 3 lifelong. First, provoked thrombosis. Well, INR 2 to 3 as per guidelines for non-APS conditions. But again, if there is a high risk profile in this patient, you will use it for a longer duration. There is no definite time limit. What if the patient has recurrent thrombosis? And this is not rare. Recurrent thrombosis, in spite of being in the target of INR 2 to 3, and you must ensure adherence to the anticoagulant that the patient is taking. Next is, you can either choose to hike the INR target 3 to 4. You may choose to add low dose aspirin, or you may switch to heparin. All of this comes with a is or maybe a recommendation. What about arterial thrombosis with antiphospholipid antibodies? Something unique about arterial thrombosis, they are at risk for recurrence of thrombosis compared to venous thrombosis. That is what the literature shows. You will treat with vitamin K antagonists over low dose aspirin only. Why should this question come about? Probably because this is an arterial thrombosis. INR 2 to 3 or 3 to 4 is recommended. INR 2 to 3 with low dose aspirin may also be recommended. So you can see the wording. You can just use vitamin K antagonists in arterial thrombosis. That is what is recommended. You don't have to start antiplatelets, and starting antiplatelets is maybe recommended. Again, this is going to have a lot of variability from physician to physician and institute to institute. What if you come across recurrent arterial thrombosis? You will again set a higher target of the INR. You may choose to do the same thing, add low dose aspirin or switch to heparin. Can be considered. Another option is adding antimalarials or statins, which could be considered. Coming to obstetric APS. What is the target, or what is the objective of treating obstetric APS? Since it's a one-way discourse and everyone is falling asleep. So what may be the target of treatment of obstetric APS? Live birth. You want live birth. Somehow or the other, preterm, whatever, you want live birth. That is the objective of treating obstetric APS. Because if you look at the 2006 criteria, everything is about the fetus. It is either miscarriages within 10 weeks, early fetal loss after 10 weeks, or preterm delivery because of preeclampsia or placental insufficiency. So this is what is existent. And here they say that for pregnant women with no history of thrombotic or obstetric events, but with a high risk profile, low dose aspirin should be considered. You will give low dose aspirin to this group of patients without obstetric or thrombotic APS with a high risk profile. If there is history of fetal loss, now it is specific. If there is a history of fetal loss in the past, it is low dose aspirin with prophylactic dose of heparin. You may use unfractionated or low molecular weight. If it is low molecular weight, what is known as prophylactic dose, probably all of you know, is a once daily dosage. Aspirin should be started if pregnancy is being planned, and heparin should be initiated as soon as pregnancy is confirmed, ideally before the 6th week, to prevent teratogenicity. Yeah, that is the same definition that has been used from the beginning. It is an antibody-based definition where you have. Should I go back to that? This is a high-risk profile, and this definition is uniform. It's lac positive. There is no recommendation for that. It is not, and it is not a recommendation. You must understand that APS would be one of the rarest causes for fetal loss, and almost always there are other causes. Even otherwise, when you diagnose a case of APS, they say that especially when it is early fetal loss before 10 weeks, you must rule out maternal and paternal chromosome, and karyotyping should be done. So yes, it is only for those who have experienced it. That is, an obstetric morbidity has occurred and no place for screening. What if the past history is of premature delivery? The recommendation is the same, but they say here low dose aspirin or low dose aspirin plus heparin. They say or is recommended considering the individual's risk profile. Risk profile means additional cardiovascular risk factors. Recurrent pregnancy complications in spite of treatment. This is something that is very challenging. And the recommendation is low dose aspirin with heparin at therapeutic doses this time. Normally, you would use therapeutic doses only if the patient has had a history of vascular thrombosis. That is the only situation in which you will use therapeutic dosage of anticoagulation, which is 0.4 to 0.6 ml of low molecular weight heparin or 40 to 60 twice a day. But if you're having recurrent fetal loss, then this is something situation where you will use therapeutic doses. Addition of hydroxychloroquine, low dose aspirin. These are two drugs that may be used. There are many more drugs that have been tried. Some have shown benefit, but they are not part of recommendations yet. IVIG in second trimester in highly selected cases. There is very poor data for this. And I think it should not be usual practice, but this is what has been put forward, and so I am saying it. Non-criteria APS. Now, this is again something that we come across. The patient is not meeting the criteria for obstetric APS, but you are asked to make a decision of what you would like to do for that patient. Anyway, the committee has also helped us a little bit. They've decided to put forward some suggestions. So it's not just an individual suggestion. So again, they say low dose aspirin or low dose aspirin plus heparin might be considered based on the individual's risk profile. What is the individual risk profile? The APL profile, previous live births, presence of SLE, all of these can help you in making a decision. This is again physician discretion. Thrombotic APS, low dose aspirin plus therapeutic dose of heparin. There is no doubt about that. So what about your NOACs? This is something that is the preferred anticoagulant probably in many settings. So there is a big trial. There were many trials, and this is a landmark trial where they used rivaroxaban and assessed the risk of thrombosis. But they used a very selective cohort. They used a cohort of APS patients who were high risk. So this high risk is a term that is being repeatedly used in high risk APS patients. And they stopped the study prematurely because they noted that the rivaroxaban arm had an increased number of events compared to the warfarin arm. Specifically arterial events, stroke and myocardial infarction. It was stopped early, and the recommendation was put forward by EULAR that avoid rivaroxaban in APS cases with high risk profile or arterial thrombosis. It should not be used. It should not be used. So the non-vitamin K antagonists, oral anticoagulants in APS. This was a systemic review and meta-analysis that came out in the beginning of 23, where 4 trials, 3 of them with rivaroxaban, and the 4th one with apixaban was compared with warfarin. And the result was replicated. That you can see the composite arterial thrombosis was increased in the NOAC group compared to warfarin. So there is definitely an increased risk for arterial thrombosis in patients on NOACs. There is no increased risk for venous thrombosis, but there is again increased risk for composite of arterial or venous, with a specific increased risk for stroke. So yes, you will not use NOAC. Maybe the recommendations are high risk and arterial thrombosis, but one must be guarded in using these drugs for various reasons if they have failed. This is something that you will come across. Not very often, but a high index of suspicion will help you in probably getting this patient over the line. So catastrophic APS, that is simultaneous involvement of 3 or more organs within a period of 1 week in the presence of antiphospholipid antibodies and histopathological confirmation. You will not be able to meet all of these criteria, but so most of them will be probable catastrophic APS. So this is not a recommendation put forward by any body, but this is what a lot of the evidence suggests, that you will use a triple therapy with anticoagulation, heparin, plasmapheresis, and steroids. But one must practice flexibility in using this combination, because one must remember that some of the most common triggers of this is infection. So we must be very careful with using steroids and plasmapheresis again. I'll conclude with this. The new ACR 2023 criteria for APS. So after 17 years, there's a revision of classification criteria, and they have brought in multiple things such as risk profiling, cardiovascular risk profiling in patients both for arterial as well as venous thrombosis. It is a weighted score, like the 2019 lupus criteria. It is a weighted score, but they brought in some new domains. That is a So far, it has only been thrombosis, vascular thrombosis or obstetric morbidity. They brought in microvascular disease. So you certainly will have the renal involvements, the pulmonary involvements as part of APS all being included or with conference now will be called APS. Hematological domain, thrombocytopenia, cardiac, valvular domains, and even new obstetric domains. That is even without fetal loss or preterm loss, with even just preeclampsia, patient having scores for meeting the criteria for APS. Why I concluded this is because we can expect a change in, I think that we may expect a change in protocol for management of APS with the inclusion of these new domains, and we may see a new change coming up anytime. So summarizing, characterization of disease is very important in Sjogren's. Hydroxychloroquine should be a mainstay of treatment for multiple reasons that we have discussed. Anti-Roe status should be part of initial evaluation in women of reproductive age group. Risk stratification is important in APS. Prompt treatment of CAPS can be life-saving. And in APS, as per the present evidence, vitamin K antagonists should be preferred anticoagulants over NOACs. Thank you for your patient listening. I can take any questions if you have any. We need either venous or arterial. Either venous or arterial is it's so when you say it is either venous or arterial. Oh no, so the role of heparin clexane apart from the bridging therapy initially would be as discussed when the patient has recurrence. Recurrent events on warfarin or acinocumarin or whatever vitamin K antagonist that you choose, the patient recurrence of events, it is one thing that can be considered. Otherwise, it is oral anticoagulant that will be used.
Thank you so much, sir, for taking the time to give that comprehensive lecture to us on it.
Thank you. Thank you.
Please join us for lunch.